There are a number of treatment regimens that are available in the treatment of relapsed or refractory large cell lymphoma. There are certainly chemoimmunotherapy programs that we choose amongst based on patient disease characteristics, patient preferences, toxicity profiles, disease biology. For patients who may have had a long duration of remission after R-CHOP chemotherapy, the regimen of rituximab and EPOC chemotherapy, or R-EPOC, remember that was originally designed and developed as a salvage regimen and is still appropriate for some subset of patients, particularly those who may not have received a full course of doxorubicin-based therapy in the first line or enjoyed a long duration of remission following R-CHOP first-line therapy. Other regimens that we use in the transplant-eligible population, typically platinum-based programs, continue to remain the standard of care, although we know that response rates, even in that most promising setting, are still suboptimal. For transplant-ineligible patients in the second line, we typically are choosing either a chemoimmunotherapy program, such as R-GEMOX, BR, sometimes RICE or the like, R-EPOC chemotherapy or R-CEP, Cytoxan, etoposide, procarbazine, and prednisone, which can be administered either intravenously or orally for more frail patients. And then for patients with certain disease characteristics and certain disease biology, like non-GCB or double-expressing lymphoma, you may look at using either rituximab combined with lenalidomide or rituximab combined with ibrutinib, again with palliative intent. In the third-line setting, options become a little bit more varied yet, and we have two therapeutic approaches that now have FDA approval for the treatment of third-line and beyond relapsed diffuse large B-cell lymphoma. The first of these is CAR T-cell therapy, and we have two currently approved CAR T agents. The first is known as axi-cel, axicabtagene ciloleucel, and the second is tisagenlecleucel. These are two CAR T-cell therapies that have slightly different toxicity profiles and slightly different activity profiles, but both of which are both approved and highly active in diffuse large B-cell lymphoma. The second option that we now have as an FDA-approved strategy is combination bendamustine and rituximab in combination with polatuzumab vedotin, which is an antibody-drug conjugate delivering MMAE and targeting CD79B, a surface antigen that is ubiquitously expressed on B-cell lymphomas, including relapsed diffuse large B-cell lymphoma.